Okay, perfect. Thank you all for coming this evening. I'm sorry I'm not the optimal height to be like making good eye contact over the podium. So I'll do my best to make eye contact throughout. I find I tend to pace when I make presentations, so we'll see how this all goes. Thank you for attending, and I'm really looking forward to any questions that you may have at the end of the talk. So my name is Sarah. I am a pelvic floor physio here in town. I work at a clinic in Oak Bay called Vela Health and at a clinic out in the West Shore called Modus Physiotherapy. Both fantastic people that work there. I thought I'd start this evening with what is pelvic floor physio, because I think it's when most people think about physiotherapy, they think sports injuries or a sore low back or something like that. So pelvic floor physio, as the name suggests, looks at the pelvic floor specifically, not completely in isolation, because you are all more than just a pelvic floor and we have to take other systems into consideration. But looking at addressing the pelvic floor specifically, because so I've been a physio for about 20 years now. I can remember you'd have textbooks and it was almost like literally a black box over like parts of people's anatomy. So it wasn't necessarily an area that we all delved into. So we look at addressing tension of those pelvic floor muscles. We look at addressing weakness or whatever dysfunction may occur in those muscles. So who can benefit? Clearly, given the topic this evening, people who have undergone a radical prostatectomy can benefit from pelvic floor physio. Often urinary incontinence is a side effect of that radical prostatectomy, as can be sexual dysfunction. And pelvic floor physio can play a role certainly in the incontinence and to a lesser extent around sexual function. In addition to that, it could be someone with pelvic pain. Pelvic floor physio can help a whole myriad of female issues as well, but I won't get into those this evening. So how is it relevant for those who've undergone a radical prostatectomy or radiation? I mentioned incontinence is the primary issue that I see people for. And it can run the gamut. It can be someone who's quite incontinent frequently throughout the day, or it could be someone who, hearkening back to my time in the Kootenays, every time you tried to get up, if you wiped out skiing, it was an issue. And it was quite specific because with having to put that much effort into getting up out of the snow and get going again. So it can really run the gamut as to what that urinary incontinence looks like. The other thing that people can experience, particularly if they've had radiation, is urinary urgency. And that need, like, you don't really get much warning. It's like, I feel like I need to pee, clear the way. I have to pee right away. Nobody better get in my way. So we'll talk a little bit about both of those scenarios this evening. So the Plumber and the Apprentice, the Plumber and the Apprentice analogy is that when you have your prostate removed, the internal urinary sphincter is removed. So what you're left with is the skeletal muscle of your pelvic floor to provide that sphincteric control. So your internal urinary sphincter is like your plumber, and he's been called away. So you have to hope either your apprentice is already up to snuff, or we can get him up to snuff to do the job for you in the long term. So just a brief anatomy review. There we go. You can see you have your bladder. Sorry for those on Zoom, I'm going to just point. So we have our bladder in the middle there, and you can see just below that, the purplish pink structure is the prostate. At the base, sort of where the bladder meets the urethra, is where that internal urinary sphincter is located. So that's what is removed. And you can see the muscle sort of sitting below that prostate gland that goes from the pubic bone at the front to the tailbone at the back. That's where that pelvic floor resides. In the literature, if one were so inclined to refer to it, the pelvic floor muscles are referred to as the anterior levator ani, a fairly descriptive word for what they do, or name for what they do. So there's also superficial and deep pelvic floor muscles. You can see on this diagram, the more superficial muscles you can see on the left side of the diagram at the base of the penis, and you can see the external anal sphincter right around the anus. So those are more of the superficial muscles of the pelvic floor. And then deep to those, you have the anterior levator ani. These diagrams go a little bit more into the urinary sphincters. So you can see, whoa, I'm just gonna go back. Good. You can see at the base of the bladder, there's the internal urethral sphincter. It's made of smooth muscle. Smooth muscle isn't under our conscious control. So that muscle just kind of does its thing. It's kind of like how you get peristaltic motion through your intestines and you don't think about digesting and passing that bolus of food along. Same thing with the internal urinary sphincter. Things just happen happily. The external urinary sphincter is the pelvic floor itself. It's skeletal muscle. So it is under your conscious control, which is why you can train it. Over time, you don't have to think about it all the time, because as I'm talking and moving my hands, I'm not consciously thinking biceps, triceps, muscles that move my fingers. Is just sort of happening. And the same thing starts to happen with that skeletal muscle of your pelvic floor. But you do have the opportunity to up-train it because it is under your conscious control. So a little bit about the bladder. The bladder is a reservoir that continuously receives urine from the kidneys via the ureters. The normal volume is between 300 and 600 milliliters. So quite a range, but we're quite a range across the population as people generally. The first awareness of needing to void is about 150 mils. Most of the time, it's kind of like the bladder's knocking at the brain and being like, hey, heads up, we're starting to fill. Maybe think about finding your way to the washroom, and the brain can either be like, why, yes, definitely, let's pursue this, or no, not the appropriate time. You're given a talk to a group of people. Maybe in an hour, you'll have the opportunity. When we have urgency, our body responds too vigorously to those lower bladder volumes. It's also important to note there are stretch receptors in that muscular layer of the bladder. So as your bladder fills, those stretch receptors are sensing the bladder stretching to accommodate the volume of urine, and then to some degree starts to have that conversation with the nervous system of looking to find a washroom. So what do pelvic floor muscles do? Not just in terms of urinary continence. They provide support for your organs. They're kind of like the buoyancy that helps shore everything up from below. They have the sphincteric control, which is what we're primarily going to talk about. They have a role in sexual functioning. They have a role in stability because your pelvic floor is part of your inner core unit. So your inner core unit, and for the sake of when I speak of the core, I'm not talking about your glory muscles. I'm not talking about your six-pack abs and your obliques. We're talking about that inner core unit, which is your pelvic floor at the bottom. It's like a little canister. Your pelvic floor is at the bottom, your diaphragm's at the top. You have your deep abdominal wall that wraps around you a bit like a girdle, and you have little segmental stabilizers up your spine called multifidus. So those four components are what make up your inner core unit, and your pelvic floor is an integral component of that. So sometimes when people have, say, persistent low back pain and are working on their core, if there's dysfunction in the pelvic floor, that can influence how that inner core unit is functioning. And then it acts as a bit of a sump pump. It helps return fluid centrally. So you don't just have like stasis sitting in your lower abdomen. So physiology of urinary incontinence. The smooth sphincter tone increases with an increase in bladder pressure, playing a passive role in continence. So that's what I was referring to earlier. That smooth muscle is not under your conscious control. And what's kind of cool is as your bladder starts to increase, it just, that muscle, its tone increases as that bladder starts to fill. The striated sphincter, which is your pelvic floor, your skeletal muscle, it contributes to passive continence by its muscle tone. And its contraction plays a major role in active continence. So passive continence, if that pelvic floor, if that skeletal muscle is of sufficient tone, it kind of helps with that sphincteric closure and prevent one from leaking. The part it plays in active continence is like, good Lord, I've waited far too long to go to the washroom. I am actively and volitionally contracting my pelvic floor to make sure nothing's going sideways until I get there. The phases of continence, you have your storage and filling phase, which is the vast majority of the time. You have your transition phase, which is when you recognize that you need to go to the bathroom and you're going somewhere to do something about it. And then you have your emptying phase. So all three of those need to be working effectively for you. So the breath, which you may be thinking, why are we talking about breath? The reason is back to that inner core unit and that canister, is that how you breathe has an impact on your pelvic floor. It's like a little piston system inside your body. So if you have your diaphragm on top, your pelvic floor on the bottom, if you take nice deep breaths that your rib cage opens and expands, that diaphragm is lengthening, as is your pelvic floor. As you exhale, they both recoil to their resting length. So that's how it's like a little piston inside your body. So where that becomes relevant is that if accessing your pelvic floor is a little bit difficult, if you exhale, you're getting this physiological recoil and shortening of the pelvic floor, which is what we're trying to achieve with a contraction anyway. So it's more difficult if you're going, I mean, ultimately, we want you to be able to contract your pelvic floor regardless of where you are in your breath cycle. But for the sake of learning how to contract your pelvic floor, it can be a really good starting point to sort of exploit this piston system. Umbrella breath is a cue that I give to people to help them get into that expansion of the lower rib cage. So as you inhale, you're thinking that your lower rib cage is like an umbrella and you're trying to breathe to have that lower rib cage open 360 degrees. And then as you exhale, things close back down again. The influence on pelvic floor exercises, I kind of talked about previously, that you're going to exploit that system and exhale when you're learning to contract that pelvic floor. And then intra-abdominal pressure regulation. A time that a lot of men can be leaky is when they're performing an activity that requires a degree of effort. Because often when we do something that requires effort, we hold our breath. And if we hold our breath, our intra-abdominal pressure increases. So we have pressure, and that pelvic floor can be, unfortunately, kind of the outlet. Like if you're holding your breath properly, you're getting pressure pushing downward on the bladder, and it may overwhelm the ability of the pelvic floor to keep urine in. So you want to make sure you blow before you go. So if you're doing anything that is a perceived effort where you might be holding your breath, it could be picking up a heavy bag of groceries. It could be gardening. It could be if you're in a chair where your bottom's been sucked down low to the earth and the tendency is to kind of rock back and rock forward and go to get out of that chair. You want to resist that temptation and exhale through the effort. So if I were, say, lifting something up, I would think, I'm going to inhale, I'm going to get ready to lift it, I'm going to exhale through the motion to help regulate that intra-abdominal pressure. Julie Weeb is a pelvic floor, or she's not a pelvic floor physio, she's a physio out of the States that does a lot of pelvic floor work. And she has some great videos on YouTube. If one were to be so interested in breathing in the pelvic floor, you can refer to YouTube and watch some more videos. So Urinary incontinence. We have stress. We have different types of urinary incontinence. There's stress urinary incontinence, which is what happens when we cough or sneeze or have to hustle across the street because a car is bearing down on us. It's when there is a force applied to the system and the pelvic floor is not quite up to the challenge. There's urge urinary incontinence, which we've kind of discussed, which is when that urge kind of hits you out of nowhere and it's like battle stations and dashing to the toilet. Under that, you can also end up with urinary frequency. Sometimes people will be like, I'm up to pee 5 to 6 times a night and my sleep is terrible. Or, I mean, some people I see might be having to pee like every 45 minutes or so, and like being able to go 2 hours is a victory. You can also have overflow urinary incontinence. That tends to be more people who have a neurological condition. So like a spinal cord injury or stroke or a progressive neurological condition. You can also have functional urinary incontinence, which is more if your mobility is compromised and it takes you a long time to get to the toilet. So functionally you're limited to get there. Or if someone had absolutely terrible arthritis that then dealing with, say, the button on a pair of pants or your dexterity is compromised, that would be a functional limitation that could lead to incontinence. And then you can have mixed urinary incontinence, which you see frequently, which is a combination of stress and urge incontinence. So then getting into treatment, I think maybe not everybody, a lot of people have heard of Kegels. And it was Dr. Arnold Kegel who sort of came up with the idea of contracting your pelvic floor, and the name has stuck. When I say first, do no harm, verbal and written instructions are generally not sufficient to really train someone's pelvic floor. We are going to go into a little bit of that tonight, but know that it's really important that if you have any questions, that maybe you do get evaluated by someone to make sure that you're not doing yourself active harm, because studies have shown if you're given verbal or written instruction, 50% of it, people are doing them pretty well, 50% are not doing them correctly, and a small subset are kind of doing them so incorrectly, they may be doing themselves a degree of active harm. So you just want to make sure that you're doing them correctly, especially if you're spending the time doing it, you're not spinning your wheels, that you're getting the most out of it possible. This is more gynecological, but a digital examination has been recommended for proper assessment of Kegels. So for men, it would be a rectal exam. There are definitely some men who are like, I prefer to keep my pants on today if at all possible, and that's fine too. It's still preferable to have someone, if I can palpate externally and get a sense of how that contraction's going, like your best way for sure is a rectal, but you can still get good information by palpating externally. I wouldn't want that to be a barrier for someone to seek treatment, to be like, not really down with doing a rectal exam. There's still a lot that can be done in person, even if that's not the most desirable assessment going. So more than just a Kegel. Relaxation is just as important as the contraction. I think when we think of strengthening, a lot of people really focus on that contraction. But it would be like if you were lifting weights, you're not just going to really focus on the whole time and maybe work out inner range. You're going to want to go through range of motion, and that relaxation is important. It's important particularly for your pelvic floor, because you need that relaxation to be able to void appropriately and at the right time. So you need to be able to contract as much as relax. I really like to emphasize motor control and coordination over than just pure strength, because your pelvic floor isn't an on-off scenario. If you bend over to pick up your cat, you're not going to have as strong a pelvic floor contraction as if you're going to help your neighbor move a couch. So your pelvic floor needs to be able to respond to different scenarios appropriately. We want to make sure that that contraction is isolated and specific. Very often what you see is butt cheeks really contracting, or inner thighs start to turn on, or people almost do like a little sit-up or something like that. We don't really want to see any of those. If I were to watch someone doing a pelvic floor contraction and I was just watching them from a foot or two away, there really shouldn't be any visual tell that they're doing a pelvic floor contraction, maybe save for the look of concentration on their face. There should be no abdominal contraction. There shouldn't be butt cheeks clenching together or anything like that. People stop breathing when they try and do pelvic floor contractions. So trying to maintain that breath, making sure that it's not just holding your breath and engaging your pelvic floor. You want to be able to maintain a normal breath pattern. So after saying verbal and written instructions are not optimal, we are going to go over a brief how-to just to sort of lay that foundation. So cues that I often offer people, you can think about that you're trying to close at the anal sphincter, like you're trying to prevent the release of gas. Again, it's not your butt cheeks slamming together and contracting, it's that anal sphincter that's closing and kind of lifting. Or you can pretend that you're stopping the flow of urine. That being said, please never practice on the toilet. I think because that cue is out there, often people will be like, oh, when I have a pee, I'm going to see if I can stop that flow of urine. Once in a blue moon, like a super blue moon, is probably not the end of the world, but you don't want to get in the habit of doing that regularly, because you can end up with voiding dysfunction long term, because having an appropriate void is a reflexive, there's reflexive processes involved, and we don't want to end up interrupting that by overly practicing contracting the pelvic floor while you're having a pee. Another cue that you can use is visualizing that you're lifting your testicles. And we spoke of this earlier, that you can key into that piston system and take advantage of that piston system by exhaling to initiate that contraction. Don't try too hard. When people try really hard, that tends to be when you see the little sit-up going on. So I think the hardest thing for people is that it is subtle and it's motor control. So you're not gonna, it's not the same feedback as if you're gonna do a bunch of sit-ups and you're like, oh yeah, I can feel the burn. I can feel these muscles working. I really don't want you to feel the burn after you do pelvic floor contractions. So it's more about that motor control and isolation. So don't try too hard. It's about awareness and coordination and motor control, which can be a little bit harder because we tend not to think about our pelvic floor until things go a little bit sideways. So sometimes the default position becomes to try really hard to try and feel more of something versus maybe taking the time, having a bit of patience, and developing that awareness over time. So what to watch out for? We've kind of touched on all of these again, but to review, don't hold your breath. Don't practice this while you're sitting on the toilet, and watch that the other muscle groups aren't kicking in. You can have someone in your life, in your family, be like, I can totally see you're doing like a mini sit-up, like, you know, give that another go. Our pelvic floor is part of our postural control system. So most of the pelvic floor is made up of slow twitch muscle fibers. That being said, about 30% of the pelvic floor is fast twitch muscle fibers, and we want to train those muscles as though that component of the muscle as well, because we want you to be able to successfully cough or sneeze, or if something comes out of the blue, we want that pelvic floor to be able to come on quickly. So what you would practice is bringing that pelvic floor on quickly and releasing quickly. From a motor control perspective, you can work on ramps. So you're going to slowly bring that contraction on over time and then quickly release. And by over time, like 5 seconds or so. And then there's a ramp. So you're going to bring that contraction on, and then you're going to hold it for a duration of time, up to 10 seconds. This and then release quickly at the end. But this also requires a little bit of, I don't know, honesty on your own part and assessing your ability to hold that pelvic floor. Because sometimes people can hold that pelvic floor for, say, 5 or 6 seconds, and then there's kind of like a bit of a drop off that they can't hold it at that level for the full 10 seconds. And in the effort of trying to maintain that strong contraction the whole time, that's when you can start to see some of the accommodation strategies kick in. That's when you can start to see maybe someone can sense the contraction is starting to drop. That's when maybe you start to see butt cheeks coming in and they're trying really hard to maintain the contraction. Or maybe you start to see more of the abdominal wall start to activate. So when you're holding, the ultimate goal is 10 seconds, but it's much better to do a really good quality contraction for the time that you can do it well, and maybe challenge yourself by 1 second versus trying to do it by hook or by crook for the full 10 seconds. So my preference is that people start doing this in lying because your other muscles are quiet. So lying on your back with your knees bent, so your back's nice and happy, and then practice contracting that pelvic floor. When you're like, yeah, pretty good at this, then you can transition to trying to do it in sitting and then maybe standing. Standing is where things can sometimes go a bit sideways. That's when butt cheeks in particular start to kick in because the rest of your muscles are more active holding you up against gravity. Sometimes because those glutes then are a bit upregulated, they're more apt to contract in standing. But again, it's about building awareness over time. And if you've done some for a while in lying with your knees bent, then making the transition over time to doing it in standing. Ballpark, 60 pelvic floor muscle contractions in one 24-hour time frame is sufficient. So it might be that you do 2 sets of 10 of the quicks, 2 sets of 10 of the ramps, and 2 sets of 10 of the ramps and holds. You can think of it as like a dosage of medication that you're going to sort of do it as prescribed. It doesn't work to be like, well, if 60 is going to be good for me, I'm going to do 120 and I'm going to get that much stronger, that much more quickly. The concern is if you over exercise your pelvic floor is that you can kick yourself into a degree of tension and end up with a degree of pelvic pain, which is really not what we're aiming for. So studies have shown that 60 in a 24-hour time frame is appropriate. So urinary urgency. You have to consider the nervous system with urinary urgency. So it's not just about strengthening your pelvic floor, it's also about calming strategies for the mind and the bladder. So if one is seized by urgency, if you can sit down and take some deep breaths, that's great. If there's nothing to sit on, you can kind of lean against a wall, prop yourself up against a wall, take some calming breaths, maybe distract yourself, maybe count backwards from 100 by 7s or by 1.4 or something like that. So you're having to mentally attend to something else. You're going to try to avoid rushing to the toilet because what you're trying to do is separate the behavior of feeling or separate the behavior of rushing to the toilet from the feeling, the strong urge. So as the urge comes on, you try and do some calming techniques. You crest the wave because typically urge comes on strongly. Hopefully you have some then strategies to get over the crest of the wave and come down the other side. And at the other side, when the urge has subsided, you may be like, yeah, I legitimately need to pee. And you can take yourself calmly to the washroom. Or it may be like, false alarm, I don't actually really need to pee that much, and then continue on with your life for a little bit longer. What happens, particularly with urinary urgency, but also somewhat with stress incontinence, is that people get into the habit of having just in case pees. That you have a just in case pee before you leave the house, or before you go to a friend's house or something like that. So just being cognizant of your just in case pees. It's fine to have a just in case pee before you go to sleep at night. It's fine to have a just in case pee if you're going on a road trip and you're going to be in the car for 3 or 4 hours or something like that. But otherwise, just make a conscious decision, because I'll for sure have people that come to the clinic that have gone to the washroom just before they left the house. They'll go to the bathroom again as soon as they arrive. They may go to the bathroom again mid-appointment, and then they'll probably go to the bathroom again before they leave the clinic. It's not everybody, but it's some people. So it's just evaluating, do you really need to go to the washroom? Because what happens is you then exist with a body that's getting used to lower and lower bladder volumes. So the body responds to those lower bladder volumes as if they are more significant. Stay hydrated. A lot of times we start to limit fluids when we're concerned about incontinence, and particularly with urgency, concentrated urine is a bladder irritant and can actually feed into that urgency. So you don't have to drink gallons, but you want to make sure that you are drinking sufficiently, that your urine is straw colored to clearish. You don't want something that's very dark. Other bladder irritants, the biggies are coffee and alcohol. Those can contribute to urgency. Other ones that can contribute are things like carbonated beverages. Less commonly for some people, it could be vinegar or tomatoes or spicy foods, but the big ones are coffee and alcohol for sure. So what to expect from a physio appointment? I would hope you'd get some exercises out of it to some degree, that you are given specific pelvic floor exercises based on how you present as an individual. You may have in the session biofeedback used. So biofeedback would be the application of sensors, ballpark either side of the anal sphincter, which then pick up the electrical activity of the muscles and then display it as like a rolling graph of the activity of the pelvic floor. So it's particularly useful for someone who maybe is struggling a little bit finding their pelvic floor, so they get some visual feedback to be like, oh yeah, that was a good one. Let's see if I can reproduce that, and just sort of see what kind of motor control I have. Is a good educational tool in that capacity. It's also good if someone has tension, because if you ask someone if they have tension in their pelvic floor, and you kind of ask them to relax, they're like, definitely am relaxed. But if you can show them on the screen that in fact they are holding this increased tension, and then give them some techniques to try and relax out of it, again, it kind of reinforces like, oh, this is possible. Oh, I can do this, and I'll work to reproduce this at home. Again, the pressure regulation and breathing is probably going to be discussed. Maybe not the first visit, but on a subsequent visit, integrating those pelvic floor contractions into function is super important. So fantastic, you can do a pretty good job lying on your back or standing still, but what's your pelvic floor doing when you are lifting something up, or when you're going to the gym, or you're doing some core work? So can we integrate that pelvic floor into functional activities? Addressing other contributing factors. Is your posture contributing to relative dysfunction of the pelvic floor? Is ongoing low back stuff a factor? Or, is there tension of that pelvic floor that's not ever really been to a level that is manifested as dysfunction, but with the prostate being removed, has it kind of like reared its ugly head to a certain extent? There'll probably be a whole lot of talking as well, a big education session, just going over everything, because again, it's a body part we don't really think about, and I find the more that people know, the better the buy-in is, and they're more likely to do their exercises. If you know why, it's not just I'm accepting this on dogma, that I know why I'm doing this. So another element would be scar care. So for your incision, is that scar tissue nice and mobile? Is it a little bit tethered? Can we get that scar tissue more mobile? So that it's not a contributing factor to either that it can be a bit uncomfortable, or is it also potentially contributing to a bit of pelvic floor dysfunction, just given that close interrelationship between pelvic floor and abdominal wall? So general prognosis. So long-term urinary incontinence is rare after radical prostatectomy, but it is a slow process. I find somewhere around 12 weeks is where like a little bit of panic starts to kick in. Like you can know cognitively that this can take up to 2 years, but after 3 months, you can tell people like, okay, I'm pretty done with this, and I'm starting to be a bit concerned as to how all of this is going. But fear not, it will still improve. Generally, men who are in their 40s to early 60s at 12 months are doing well. And 80% of them, save for an occasional drop at 3 months post-op, are doing very well. Like most things in life, the older we get, it becomes a bit more challenging, but it doesn't mean that you're scooped. And again, you can have improvement up to 2 years. The jury is not out until around 2 years or so. So erectile dysfunction, I just thought we'd touch on this. Not that I, as a pelvic floor physio, can do a ton about it, but it's always something I ask people about, just to make sure that conversation is being had with the urologist. One's baseline erectile function has a huge influence. So if one was having erectile dysfunction pre-surgically, your outcome after is going to be a bit more challenging. 12 to 24 month recovery, again, long recovery. The surgical approach that's taken and the nerve sparing is important. You can have neuropraxia, so that's just short-term compression, decreased blood flow to with swelling and all of that has gone on with surgery. One could also end up with some structural changes. Scar tissue, less likely, but have those conversations with your urologist. So treatment is not a physiotherapy intervention. It would be having conversations with your urologist about medications, vacuum erection devices, injection, surgery. So prognosis, sexual functioning with pelvic floor muscle training alone. So after 12 months, they're small sample size as well, so take all of this with a grain of salt. They're not huge studies that are done. About 50% doing pelvic floor exercises recovered erectile function, whereas in the control group, 12% did. So there was a change. It wasn't overwhelming, but there was an improvement in the intervention group versus the control group. So, and then just general advice post-operatively, if anyone is heading into surgery versus have already been through it, don't try and do pelvic floor exercises while the catheter is still indwelling. Make sure your bowels are in good nick. If you have to take a stool softener, take a stool softener. Don't be having to strain or anything in that post-operative period. You can think about that intra-abdominal pressure regulation. You can think about blow before you go, as you get out of a chair, as you go from lying to sitting, as you get out of bed in the morning. The scar techniques, you're only going to initiate once you're well healed, once you get the blessing from your doctor or a physio, because obviously you don't want to mobilize scar tissue that is still on the delicate side of things. And most importantly, follow the protocol that you're provided. Resist the urge to lift heavy things and be too helpful about the house, and really allow yourself to recover from surgery. Does anyone have any questions?
There were a couple of questions in the chat here.
Okay.
So I can read them aloud because I think they were sent directly to me. So there's a question, with BHP, does colonoscopy present a danger?
I don't know that. I would ask the physician. I don't know. I shouldn't weigh on that. That's beyond my scope of practice, so I'm not going to weigh in on that. That would be a question for the family doctor.
No problem. And there was a second question in the chat regarding prostate enucleation, a new term to this person who asked the question. Is pelvic floor physiotherapy needed?
I would say only if you're experiencing any kind of dysfunction. That if, sort of like anything, there are some people that I've seen